So it is my great honor to introduce our keynote speaker, Dr. Elena Elimova, who is a medical oncologist at Princess Margaret Cancer Centre, associate professor with the Department of Medicine, Division of Medical Oncology at the University of Toronto. Her main focus in research is to improve outcomes of patients with gastroesophageal and pancreatic malignancies. She has concentrated on big data research, translational studies, and the development of clinical trials. Nationally, she is the co-chair of the esophagogastric disease group for the Canadian Cancer Trial Group, and internationally, she is a member of the National Cancer Institute. She is a personal friend and a mentor, and it is my great pleasure to introduce her today.
Thank you so much for allowing me to speak. I hope my voice, I'm told, generally carries well. I think we do this for all of you here. You know, patients and caregivers is why we get into the practice of medicine, and I live with so many people's faces in my mind, you know, as I enter my 11th year in practice. So I will be talking about gastric cancer care and research and where we are now. I'm just going to give you a moment to look at my disclosures. So in terms of stomach cancers, I just want to point out that they are a major problem globally. You know, gastric cancer is the 5th most common cause of cancer-related death worldwide. And even though we see gastric cancer primarily in Asia, we also see it in poorer regions in Europe, and of course, as our surgical oncology colleague will be telling us, in parts of South America. So I just want to point out certain risk factors for gastric cancer. So these don't mean that just because you have a risk factor, you're going to get the cancer, but they are certainly risk factors. So H. pylori, the presence of GERD, obesity, and then dietary choices. I often get asked by patients when they come to see me, do I have a genetic cause of cancer? And I just want to point out that only 1 to 3% of all gastric cancers are caused by genes. So what I do tell my patients is probably some kind of combination of the genes that we're born with and then the environmental factors that we're exposed to that end up in the development of the cancer. So this is what the upper GI anatomy looks like. You know, when I think about gastric cancers, I think of, you know, at first the esophagus, a very thin tube, then the connection between the esophagus and the stomach, which is the G junction, and then I think about the stomach. And when we think about gastric cancers, the majority of these cancers are adenocarcinomas. And we do see intestinal and diffuse types of tumors. This is something that our pathologists tell us. I've seen many pictures, but to me, how I treat the cancer doesn't depend on the fact if it's intestinal or diffuse. So what are some of the signs and symptoms of gastric cancers? Well, I think the really big problem with stomach cancer is that it's a very silent disease, and it's often diagnosed at later stages. So approximately 40% of my patients would be diagnosed with stage 4 disease. And why is this? And that's because some of these signs and symptoms that gastric cancer causes can be thought to be due to something else. So we see early satiety, difficulty swallowing, weight loss that's unintentional, generalized abdominal discomfort, heartburn, nausea, vomiting. A lot of times, the only thing we might see is microcytic anemia, meaning that the cells in the blood look small. And I think the last thing that I often warn patients about is if you ever have symptoms of reflux that don't respond to a proton pump inhibitor, you should be advocating to get an endoscopy. So how do we diagnose gastric cancers? Well, first, thanks to our surgeons or our gastroenterologists who are sitting in the audience, we do gastroscopy and biopsy. Often what they see, is for example, a mass. Sometimes they don't see a mass. Sometimes they just have trouble putting in air in the stomach, in cases of rhinitis plastica, for example. Why is this so important to a medical oncologist? Well, number one, before I treat a gastric cancer, I need to know what type of gastric cancer it is, but also I need to test for a whole bunch of different proteins known as biomarkers that will help me tell my patient what type of treatment should they get. The other thing that is needed, obviously, is CT scan staging. So we do CT scans to tell us, is this cancer localized or has it potentially spread to other areas? The other common question I get from patients is, Dr. Elimova, should I get a PET scan, and does that help? But unfortunately, the places where gastric cancer spreads to, for example, the peritoneum, they're not well visualized with a PET scan, as I tell my patients, and this is a part of the reason why actually PETs are not covered. The most aggressive types of tumors, signet ring cell, gastric adenocarcinoma, actually are not PET avid at all. So I think doing a PET sometimes gives people this false sense of security. And then the last thing is laparoscopy. And laparoscopy is extremely important, and I think I don't need to preach that to the surgeons sitting here. Anyone who has more than what we call a T2N0 tumor, so very early gastric cancer, should have a laparoscopy. And that's because even when we think on CT scans there's been absolutely no disease spread anywhere else, on laparoscopy we find evidence of peritoneal disease in approximately 20% of cases. So, what are the biomarkers that the gastric cancer should be tested for in Ontario and in Canada? What are the things that help us make treatment decisions? Well, there are 4: mismatch repair, PD-L1, HER2, and Claudin 18.2. These are done reflexively in Ontario, meaning that as soon as the pathologist sees a diagnosis of gastric G-junction tumor, these will be automatically ordered. And the reason that we've tried to do this and incorporate this into guidelines is that I, as a medical oncologist, want to see these biomarkers by the time the patient is walking into the room and talking to me about a consultation. So I want to have a fulsome discussion with the patient. What about next generation sequencing? Because this is the next most common question that I get asked by patients. So next generation sequencing is interesting. It is not something that is covered by OHIP currently. It can be accessed through private pay. But I just want to tell you that we don't usually use next generation sequencing to determine your treatment options up front or as we decide what we're going to give patients first. And what we do use, which are these 4 biomarkers that I've mentioned, are all covered by OHIP. So where next generation sequencing is helpful is if we find a targetable mutation. What does a targetable mutation mean? You can't just have a change in the tumor. A drug has to exist somewhere, and it has to be approved for another indication. So I tell my patients that the chances of finding this type of targetable mutation in gastroesophageal cancer that is not covered by one of these other biomarkers is probably 5% or less. So this is not something I need now. This might be something that I would be looking forward to look for treatment options as we run out of other proven treatment options. So why do biomarkers matter? Well, I think they've kind of helped us direct our therapy. So there are some biomarkers which are targeted. We know and we have drugs that we can use. Now there are other biomarkers for which gastric tumors could be positive for. An example is CMET, but they're not currently funded, and there are not a lot of drugs which have been proven to work in gastric cancer to target CMET. So another way to access these potential biomarkers, as I said, is later on, once we've exhausted the prior treatment options that are proven to work in the cancer, through clinical trials. So what does work? So this is HER2, human epidermal growth factor receptor 2. This is a protein which is found on stomach, breast, colorectal, ovarian, lung, and prostate cancers. It happens in about 10 to 20% of stomach cancers, and it is targetable, and its target is covered in Ontario. So the drug which we currently use is Trastuzumab. or in the second line, we use TDXD. I do want to point out that if a patient has a PD-L1 positive tumor in the first line, in addition to getting Trastuzumab, they will also get Pembrolizumab, which targets the PD-L1. So I just want to show you this as the fact that I think research is evolving and changing. This is a study we presented at GI ASCO as an oral. Trastuzumab has been an agent which has been used for, well, the last 15 years. But there is a new agent which seems to have some activity in gastroesophageal cancer. It was shown to improve survival by about 7.2 months when it was compared to standard of care chemotherapy plus Trastuzumab. Now, obviously, you guys are aware that that standard of care has slightly evolved. This was a 3-arm study. And the IO used, the immunotherapy used in this trial was Tislelizumab. Now, once you have a positive phase 3 study, what has to happen is it has to be reviewed by Health Canada, the FDA. This is ongoing. So this is not yet funded or Health Canada approved. But hopefully it will be like many of our drugs. What about PD-L1? So PD-L1 is a programmed death ligand 1. So what does PD-L1 do? It helps mask the tumor cells. So what PD-L1 does in our body is protect our own cells from our immune system. If we didn't have PD-L1, we would be attacking our cells everywhere. So what the cancer cells do to evade the clearance by the immune system is they start to overexpress this PD-L1, okay? And that's what makes kind of cancer grow and hide in our bodies. So this is present in about 40 to 60% of stomach cancers. And what we do to target this is in the first line setting, in addition to chemotherapy, we use Pembrolizumab or Nivolumab, which are both funded in Ontario. One of the best biomarkers to have is this mismatch repair protein. So patients that have MSI-High tumors do the best when they're exposed to immunotherapy. Why? Because these proteins normally repair DNA in your body. If these proteins are defective, you get a lot of DNA errors. And this is what we mean when we say mismatch repair deficient tumors. I will tell you that the average survival of patients with mismatch repair deficient tumors has surpassed 3 years when they're treated with immunotherapy. So obviously, I as a medical oncologist and my patients are very happy to see this biomarker, although it is rare. Only 5 to 10% of patients will have this, but it should always be checked. And then the last biomarker which has been approved is Claudin 18.2. This is a biomarker which is found in the tight junctions of cells. As you guys know, as cancers become cancers, the cells start to kind of separate from each other. That's how they get into the blood and move around the body. That's how metastases are formed. This leads to this Claudin 18.2 being exposed. So what we now know is that adding zolbetuximab to chemotherapy helps patients who are Claudin 18.2 positive. And that's defined as 75% or more of cells being positive live longer. So this is another breakthrough for us and another step forward for our patients. So let's talk a little bit about standard of care and how it's evolved. I think probably a lot of you know this study was published in the New England Journal of Medicine. It looked at this is now in cases of localized gastric cancer. They looked at the addition of an immunotherapy agent, which is called Durvalumab, to FLOT, which is our standard of care. So what they found in this study is that the addition of Durvalumab improved survival by about 6% at 2 years. What's important to know about this study is that it is Health Canada approved. However, it is not currently funded in Ontario, which means that the only way this can be obtained is either through private insurance or private pay currently. Unfortunately, we currently do not have a compassionate access program, but I certainly hope that this will soon be approved for our patients as well. Now, this is the complicated discussion that I have, and I swear, please don't get discouraged by this slide, as I often do, but this is what I was working on last night, and this is the discussion I have with my patients in clinic. how do I decide what biomarker I should pick depending on your biomarker, depending on what your tissue shows? Depending on what your tissue shows, sorry. So first, if my patient has MSI-High disease, I am going to pick immunotherapy for that patient if they have stage 4 cancer, okay? If the patient, so when we think about the rest of the disease, we think about HER2 positive disease. If the patient has HER2 positive disease, which is PD-L1 positive, we're going to give them HER2 targeted therapy plus immunotherapy plus chemotherapy. So kind of a lot of therapy. If their PD-L1 is negative, they don't express anything, it's just chemo and HER2 targeted therapy. What about HER2 negative disease? Well, in HER2 negative disease, we're going to look at, is their disease PD-L1 positive? Is it PD-L1 negative? If the disease is PD-L1 negative or positive, we're also going to look for Claudin positivity. So PD-L1 negative, Claudin positive, it's easy. You're going to give them zolbetuximab plus chemotherapy. If the disease is PD-L1 positive and Claudin positive, you have to have a discussion with your medical oncologist. This is where kind of the treatment decisions get a little bit more complicated. And for just PD-L1 positive, Claudin negative, it's reasonable to consider chemotherapy plus immunotherapy. So, second-line therapy has also evolved. In HER2 positive disease, we have TDXD. For HER2 negative disease, we have FOLFIRI or paclitaxel ramucirumab, and how we make that treatment decision depends on the toxicities or complications that the chemotherapy causes. And the last, in the third line, we have TAS-102. Why am I showing you this? Well, when I started doing this 10 years ago now, 11 as a staff, there were only 2 approved treatment options in this disease. This is how far we've come. And I hope that gives you all hope, because to me as a medical oncologist, this gives hope. Let's talk about clinical trials versus standard of care and what you should choose. Because I think this is the most common kind of myth that I have to deal with when I'm seen by patients in my clinic. So what's a clinical trial? Well, it's a study which is trying to determine the safety, efficacy, and effectiveness of a novel treatment. What's a common myth that I get told by a patient? That a clinical trial is a better treatment option than standard of care. That is not something that I as a medical oncologist know. We have new promising treatment options coming to this cancer every day. But when you walk into my office and when we're having a discussion about a clinical trial, I am hopeful and I think there's promising data. But I don't know if the novel treatment option will be better than our standard of care, okay? So what are the things that a patient should consider before they choose between clinical trials? Well, I think they should consider their quality of life. How far away are they having to travel? Are they willing to come in every 2 weeks? Because on trials, because we're measuring safety and we want to follow patients very, very closely, you're usually seeing us every 2 weeks. And remember, standard of care treatment options were once tested in clinical trials too. If they didn't work, they wouldn't be standard of care. Remember, when we randomize patients on clinical trials, we're not picking whether they go on a new treatment or on the standard of care option. That is chosen randomly. That's what randomization means. So you have to be okay with uncertainty when you go on a clinical trial. So I'm just going to show you a little bit of the kind of trials we have in Princess Margaret Hospital. But the main thing that patients should know is that in order to be considered for a clinical trial, what we need is for your medical oncologist to send a referral packet so we can review, is there anything that would exclude, for example, the patient from this clinical trial? We would communicate that to the medical oncologist if anything exists. They would communicate that back to the patient. If we think that it looks like the patient could be a candidate, then an appointment is booked. So in case you're interested about some of the research we're doing, this is just a QR code, which is linked to a patient website that you can look at. And also the other common question that I get asked by patients, so I just want to show you this. How do I search for trials on clinicaltrials.gov? And this is how you do it. So you go on clinicaltrials.gov, You can search under gastric cancer. You can pick Canada as the country. But again, the best thing to do is to speak to your own medical oncologist and get them to initiate the conversations. What about translational research studies? I really think these are very, very important studies. So this is the kind of bench to bedside research that we try to do. It's really meaningful because we're trying to figure out what is driving gastroesophageal cancers. We've found some biomarkers, which I've shown you, but if I was a betting person, I believe there are more that are still undiscovered. You have to know that even though these translational studies may not help you, they are being done to potentially help future patients and future generations. So why do people do these studies? Why do they participate in them? Well, to advance scientific discovery, to help future patients, and to also kind of pay it forward. And I think a lot of patients, at least in my experience, are very open to participating in these studies. There are studies where we might, for example, collect blood or tissue and clinical data that help us learn how clinical treatments that work in studies work in the real world once we apply them. So this is, again, a link for translational research studies at UHN. And what can I conclude as a medical oncologist who does this type of research and who treats patients with gastroesophageal cancer? Well, since my first talk and my gut feeling in 2021, our treatment options for gastric cancers have grown exponentially. I was told a long time ago by one of my, let's say, senior colleagues, why do you want to study this disease? And I have personal reasons, obviously, as many of us do. There's nothing. There are no new agents. And I said, well, if no one ever does any research in this disease, nothing will ever move forward either. And I think, the newer targeting agents, for example, HER2 and Claudin 18.2 are very promising. But our goal is to balance quantity and quality of life by developing more personalized and diagnostic and treatment options for patients. And so that's where I'll end.
Thank you so much, Dr. Elimova.